I should make a conflict of interest statement. I'm going to talk about the big trials that we've done in terms of looking at anastrozole and tamoxifen. The materials and some partial support came from AstraZeneca, so that's there. They had no involvement in the interpretation of the data, but they were certainly involved there. So there are two approaches to cancer prevention. I think it's important to recognize that we need both of those. One is simple, minimally toxic interventions for everybody, things like weight control, increased exercise. That's good for everybody. Even aspirin, which I think Gaddy's going to talk about a little bit, looks like to be something that virtually everybody should be taking. But in breast cancer, we have interventions which we know work, but there is some toxicity. So focusing our intervention on those that really need it is a particularly important aspect of that. So if we wanted to get a 25% reduction in risk of any disease, I'm taking breast cancer, one way would be to try to get everybody to change their habits and get a 25% reduction with things like diet and exercise. And that's certainly possible. But the other approach, it doesn't go on the screen, I guess. No, okay. Is to focus on, is to try to identify a subgroup. This graph identifies 20% of the population that has a threefold risk. And if we were able to get a 42% reduction just in that 20% of the population, that achieves the same 25% risk overall as trying to get everybody to do something. So focusing on high-risk populations is important. We're not too far away from actually doing that, but the ultimate goal would be to find 10% of the population at about a little more than five-fold risk. And if we were able to get a 45% reduction in that group, that would achieve, again, the same 25% population risk, but just by focusing on the highest 10%. So that's a really important concept. If we can focus our activities on individuals, in this case women who really need it, we can make a bigger impact with just focusing on a smaller group. Now, there are two key ingredients to making that strategy work. One is that we need to identify high-risk women. Who is at high enough risk to really justify some kind of prophylactic intervention? And secondly, once we found them, it's not too much point in finding somebody at high risk of breast cancer until you've got a minimally toxic prophylactic approach that we know to be effective. So in terms of the first activity, we've developed a model which has been going for about 10 years now with various innovations as time goes on. It's become known as the Cuzick or IBIS model. We're in version 8 now. It's freely downloadable for anybody who wants to use it. You can simply go to the IBIS website and download that. And basically, it's a very simple model that allows you to project risk. So what's new in version 8? In all the older models, we had classic things like age, of course, is crucial, height, age at menarche, age at first child, age at menopause, body mass index, height and weight in particular. Hormone replacement therapy is very important. Proliferative benign disease is very important. And obviously family history and a bit of BRCA testing. So what's new in this model is that we've actually incorporated breast density, which is probably the single most important risk factor for who's going to get breast cancer in the future. We delayed that for a long time because it was measured so many different ways. We didn't know quite how to do that. And we finally realized that you just check how you measured it. Was it by BI-RADS or visual assessment or by a Volpara volumetric measure? And then we just calibrate the results according to that. So that's in there. We've actually included not only biopsied benign disease, but aspirated cysts, where many of those are actually proliferative when they are actually biopsied. And risks for cysts overall have been found to be between 1.5 and 2-fold. So we've added that as well. And then the third area, which looks promising, and I'll say just a little bit about that, are these single nucleotide polymorphisms, or SNPs, which are increasingly important. The geneticists would probably try to tell you that they're the most important factor, but in fact, our data suggest that they're one of 3 important things, each with about the equal value. One is just the questionnaire data from our model. The second is breast density. And the third is a SNP score based on a range of not just BRCA, we're not talking about BRCA1 and BRCA2, we're talking about common low penetrant SNPs, 20 to 30% prevalence in the population, each one of them, but only a 5 to 10% typical risk effect for one of them. So individually, they're not very useful, but when you get a panel of 50 or 100 of them, you begin to be able to make useful data. So this is all easily input from, this is what you get when you ask for the program. It's basically, you put in the basic factors there, age, menarche, height, weight, parity, and a whole range about this. Then you can also, you sort of put in the family history of breast and ovarian cancer, whether it's bilateral or not. And as you put that data in, it builds up a pedigree, which tells you, here's the woman, she's age 40, her mother had breast cancer at 55. You can build up a whole pedigree here. And it also keeps track of the number of unaffected sisters and what their age is, which helps to lower risk. And then you say, calculate risk up here, and it gives you a simple figure here, which women easily understand. The blue line is the average risk for a woman at the same age, and then the red line is the personal risk. This woman had a family history, so her risk is about doubled. You get a personal and a population risk. What's the 10-year risk and what's the lifetime risk? So she's got about a double the 10-year risk, 3.2% versus 1.6%, and about a double lifetime risk as well. So that's available. You also get details about the likelihood of being a BRCA1 or BRCA2 mutation carrier. So the new factor, which has not been built into really any of these prior models, which is now in our version 8, is mammographic breast density. And there's still, I think, a lack of appreciation about how important this is. And mammograms are used essentially just to look for small tumors and affect early diagnosis, for which it is useful. There's no doubt in my mind about that. But equally important and not so much used is the fact that the difference between a fatty replaced breast over here on the left and a very dense breast on the right is about a 4-fold risk with a real gradient across that. And it's not really hard to be able to assess that, although we do need better ways of picking up some of the textural features which aren't so well understood yet, and some radiologists pick them up better than others. But you can see here, this is one of the early papers. There's been about 24 confirmations of all of this, that there's between the lowest risk, which is less than 10%, and that's about a third of the population, to the high-risk groups, there's about a 4-fold risk. And about 4% in that high-risk group, another 13% in the 50 to 75%, where they have a 2.5-fold risk. So this really is an important factor. And if you look at population attributable risk, you can attribute more risk to the information on the mammogram than you can by family history or any other known factor. So we really should be using this more. Just briefly, there's been now interest in looking at how breast density and the SNPs combined work. We've done a lot of analysis on that. Not a lot is published. We've just got one paper, the 10% reduction in their visually assessed mammographic density. This was done blind to treatment, and found that in fact the benefits of tamoxifen were only in that about half the population that had more than a 10% reduction in breast density. There the effect size was about 2/3, whereas those that didn't have a reduction in breast density got no benefit. So we may be getting to develop some of the first biomarkers for response to endocrine therapy by looking at breast density. If you don't get a right reduction in breast density, that's an indication the treatment's not working, both in the adjuvant and the preventive setting. It's been seen now. And we probably need to think a bit more about what you should do for that. Okay, well, there have been a number of other SERMs. I'm not going to go through them in detail in the interest of time, but Raloxifene, lasofoxifene, and arzoxifene all started out as osteoporosis drugs, and there have been large trials of those in women with osteoporosis. And as an interesting secondary endpoint, breast cancer incidence has been looked at. And they've all shown bigger effects than tamoxifen in that osteoporotic population of the order of 60% rather than 30 to 40%. The only trial to compare them directly was the STAR trial in the United States. It was almost 20,000 women to see a difference between tamoxifen and raloxifene. And that study showed pretty clearly that raloxifene is not as effective as tamoxifen in terms of preventing new breast cancers in high-risk women, nothing to do with osteoporosis anymore. There was about 25% more cancers than the raloxifene. It still is preventing cancers because if you looked at the control population, it'd be way up here, but it's not as effective as tamoxifen, which is the lowest line there. So moving on now to aromatase inhibitors. They've essentially replaced tamoxifen by the treatment of ER-positive postmenopausal breast cancer. I was fortunate to be the statistician on the ATAC trial, which was the first adjuvant trial of aromatase inhibitors. And again, we saw this very clear evidence that by looking at contralateral tumors, we were getting bigger effects with anastrozole than seen with tamoxifen, a 50% reduction in new contralateral tumors in anastrozole compared to tamoxifen. So that was pretty exciting. That's now been confirmed in a range of adjuvant studies. You can see here they're all showing about a 50% reduction in new contralateral tumors. That gave us excitement to actually go forward to do the prevention trials. So again, if you put that together, if you're getting a 50% reduction, which you see in women with breast cancer, essentially ER-positive contralateral tumors, and another 50% reduction is what's left, you might hope for up to a 75% reduction with the AIs compared to no treatment at all. So IBIS-II was our study. There have been two studies, a MAP3 study using exemestane and ours using anastrozole. This was just about 4,000 patients treated for 5 years with anastrozole or a matching placebo, postmenopausal women at increased risk of breast cancer, no hormone replacement therapy allowed. Doesn't make any sense to take away estrogen with an aromatase inhibitor and then give it back. So we said no HRT. And the results were very much as hoped for. We got this slightly more than 50% reduction. Is a 53% reduction in all breast cancers from 5.6 to 2.8. And if you look at ER-positive invasive cancers, it's a 58% reduction, highly significant effects. So very much as we'd hoped for. Some interesting other things is that for reasons which we don't really understand yet, is we also saw a substantial reduction in non-breast cancers. They were basically skin cancers, both melanoma and non-melanoma skin cancers, with more than a 50% reduction in those cancers. Placebo controls, so no real biases there. And colorectal cancer, which was seen previously for tamoxifen, this is the first report with an aromatase inhibitor, and it hasn't been seen in the adjuvant studies, but a really substantial reduction in colorectal cancer. Again, that's just a hypothesis that needs further validation. No real increases. Endometrial cancer has been reduced. We think that's a real effect because of the reduction in estrogen. Ovarian cancer is also down, again, small numbers. No real effect, and nothing has really gone up, nothing serious there. So interesting additional potential benefits from anastrozole, which need further validation. Now, the other area that's, I think, turned out to be really important from this trial is that there's a widespread belief that the aromatase inhibitors are very difficult to take because of the musculoskeletal aches and pains that have been attributed to these drugs. Also, there's concerns about fractures. In the early adjuvant studies, there was about a 50% increase in fractures when nothing was done. In our study, we required all women to have a baseline DEXA scan. Women who were osteoporotic or osteopenic took bisphosphonate concomitantly. It was required if you were osteoporotic. And after that, we got a non-significant, very small increase in fractures of just 11%, not significant. So it looks like you can manage the fracture risk by just keeping an eye on bone density and treating that in addition to your risk of breast cancer. Now, the more interesting question was the musculoskeletal aches and pains. And yes, we found a lot on tamoxifen. We found 64% of the women reported musculoskeletal aches and pains on anastrozole, which was pretty much in keeping with what people thought. But this was a placebo-controlled trial. We found 58% on placebo. So in all of these non-randomized studies, all of these aches and pains are attributed to the drug. But in fact, it's only about a 10% increase. Aches and pains are part of life when you get to be that age. And of course, if I had something to blame my aches and pains on, I certainly would. And it's very clear that most of these aches and pains have got nothing to do with the treatment. Some do. We see an increase in severe from 6% to 8%, moderate from 19 to 22%. But the vast majority of these complaints are not related to drug and seen almost as commonly in the placebo group. So that was really quite interesting. The things that we do know is that muscle stiffness, joint stiffness, and carpal tunnel syndrome are rarer, but they are associated with aromatase inhibitor treatment, and that was confirmed in this study as well. I'm not going to say too much about this. Some increase in vasomotor symptoms, very much is seen with all of the anti-estrogens, that you are making menopausal symptoms more difficult, and that's an area that we have to acknowledge. Severe, again, only in like 8%. It's not a reason not to give these treatments, I think, in prevention to start. Many women have been frightened to even give it a try because of the concern about this. But the simple thing to do is try it. If you don't like it, stop. They go away. It's not a permanent problem. And I think that's a better strategy, to give it a try. If you don't like it, you just simply stop. So again, there was another study, MAP3. It got virtually the same effects. It was with exemestane. The follow-up was not so long, but you get virtually the same effect on all breast cancers, invasive breast cancers, and ER-positive breast cancers. They all seem to show about a 50 to 60% reduction, with a little bit bigger effect in the exemestane study, but confidence intervals overlapping. So I think there's no real difference between the aromatase inhibitors for prevention. Both of these work, and probably letrozole does as well, but it's never been tested. So just to finish, I'd like to talk a little bit about some of the new developments that are ongoing now. One is high-risk postmenopausal women, like premenopausal women. All we've got for premenopausal women now is tamoxifen. We did a study some years ago, was finally reported by Tony Howell, who led the study just this year, looking at Zoladex, which is an LHRH agonist, which knocks out estrogen produced by the ovaries. In younger women, it's like an AI, but it works premenopausally. And then we gave Raloxifene as well to sort of look after the bone and see if that would make things at all better. And basically, this was just a pilot study to see how it went. Recruitment was a challenge. Over 7,000 women were actually screened, recruited about 10% of them, 50-50 into the two arms. Side effects were difficult. Taking away estrogen in premenopausal women really is a big challenge, and this really takes it all away. So I think that strategy is one that's very difficult. It's been proposed now that we actually should use an aromatase inhibitor. We should use something like this, but maybe give back a small amount of tamoxifen. Well, if you gave an aromatase inhibitor, an LHRH agonist, and a little bit of testosterone, the testosterone would not be converted to estrogen because of the aromatase inhibitor, but you would actually have a big effect on reducing these menopausal side effects, which are reduced by androgens as well. So that's an interesting strategy which is yet to be fully developed. This was just a pilot study, so it's only just looked at reductions in breast density. We got big reductions in the first year from a start of about 48% down to about 37%. It continued in the second year. Treatment stopped after year 2, and you got a bit of a rebound. By the second year, it wasn't. By the third year, it was similar to the control population. So the intention would be you'd probably have to give this for at least 5 years to get a benefit. So we don't really quite see a way forward with this unless we could do something in addition to control menopausal symptoms, but it is an interesting approach as well. The other thing we've been looking at, and we're just at early stages, is that I think we have difficulty convincing women that the side effects of tamoxifen are not as bad as many people would say. And maybe rather than trying to say, give it a try, if it doesn't work, stop, we've got a different approach, and this is looking at a gel or a topical application of Endoxifen, which is the major active metabolite of tamoxifen, and you apply it directly to the breast. And the anticipated hope, and there's some evidence for looking at other gels with afamoxifene, which is a similar drug, that you get a high dose at the breast, but a low systemic effect. So if this works as we hope, we'll get an effective dose to block the estrogen receptor in the breast, but a low side effect profile because you wouldn't have a dose systemically. And we're quite excited about looking at that. All that's been done thus far is a small phase 1 study to show that this is well tolerated, 3 doses of Endoxifen, 6 patients at each dose and 2 in placebo. And basically, the side effect profile was that there was really no detectable side effects to be seen with the treatment in these small numbers. Just a tiny 2% had mild or moderate effects, and very, very little. So it seems to be well tolerated. Our plan now is to move to a phase 2 study to take women with dense breasts to do a placebo-controlled 1-year treatment with the primary endpoint saying, can we get this reduction in breast density, which has been such a good predictor of response to other endocrine agents. So that's exciting. If we could actually get the benefits of tamoxifen without the side effects, I think that's an exciting option, which we are actively pursuing. So just to conclude, 5 years of tamoxifen produces a long-term 30% reduction. This new topical Endoxifen may reduce the side effects. That's the new excitement there. The aromatase inhibitors are more effective and less toxic. There's none of the severe problems like endometrial cancer or thromboembolic complications you see with tamoxifen or the SERMs, but you can only use that in postmenopausal women. And I think one of the challenges is to find effective preventive methods for premenopausal high-risk women, where that's probably the place you want to be doing this in the mid to late 40s. So thank you very much. Happy to take it.